Welcome back to More Health, Less Healthcare. I'm Peter Boland. In this episode, we're going to look at part three, housing. Perhaps, most considered linchpin in many of the social infrastructure initiatives around the country today. But we're going to talk about from an institutional investment, not a community investment, but an institutional investment in the community. So let's start off with a challenge. Imagine you're a physician managing a patient with uncontrolled asthma. You prescribed, the right inhaler. You've given, the right instructions. You've scheduled a follow-up appointment. And every 6 weeks, the patient is back in the emergency department. Imagine you find out that their apartment has black mold, cockroach infestations, and a landlord who hasn't responded to complaints in over 2 years. The clinical problem, it isn't the asthma. The clinical problem is the apartment. And no prescription in the world's going to fix the apartment. So there's a saying, institutions need to change, not people. That's how one health system executive put it. And the organizations in this episode took that sentence seriously enough to put some real capital in back of it. Since this is the first of the two episodes on housing, this one is about what happens when hospitals and health plans, the institutions, decide that housing is their problem to solve. The next one, we'll talk about what happens when they hand the decision-making to the people who actually live in the neighborhood. That'll be the next episode. So let's look at Nationwide Children's Hospital. I'd call this treating the neighborhood as the patient. And Children's Hospital in Columbus, Ohio, took one of the most powerful conceptual leaps in this entire series. They looked at the communities as their patients where they came from, communities defined by intergenerational poverty, disinvestment, and predictable health consequences of both. And they said, the neighborhood is the patient, our patient. Now that frame, to me, changes everything. If the neighborhood is the patient, then education is a clinical intervention. Workforce development is a clinical intervention. Community safety is a clinical intervention. Affordable housing is a clinical intervention. You get the picture. And the hospital's resources, financial, political, and operational, are legitimately deployed in service of that broader patient. And in this particular case, Nationwide Children's looked at it as an intergenerational commitment to break the cycle of poverty itself. So in 2008, Nationwide Children's launched Healthy Neighborhoods, Healthy Families to revitalize Columbus's South Side. And that's where high foreclosure rates, vacancy, and poor health outcomes reflected just decades of institutional disinvestment, private sector and public sector. I want to make the point that none of this is charity accounting. The hospital's Partners for Kids, ACO, carries full financial risk for 470,000 Medicaid enrolled children, which means every dollar spent fixing a house is also a dollar of actuarial self-interest. This is important to note. CFOs have to be on board and actually lead economic development. If you want to impact health, we have to talk about economic development. And the results really back that investment. ER departments visits dropped by 20.8%. Inpatient admissions fell 12.7% in targeted neighborhoods, compared with other similar areas around Columbus. And peer-reviewed reporting also found big improvement in neighborhood vacancy rates. The conclusion was the hospital's involvement increased the speed and scale of redevelopment after decades of redlining and institutional disinvestment. So this is the long-term thinking, an industry that almost entirely organized around short-term financial cycles, which don't, short-termism is a recipe for disaster. When we look at financial cycles, it can't be every 30 days, 90 days, or even a year. The board of a hospital that invests in neighborhood revitalization won't see the full return in the next fiscal year. That's just a reality. They'll see it over a decade in reduced hospitalizations, avoidable hospitalizations, better chronic care management, and healthier children staying in school, starting school, ready to learn. So here's a takeaway. At the heart of it, it's a government argument as much as it is a clinical one. And it's one that more hospital boards really need to be willing to make. Not in 10 years, not in 5 years, but this year. So let's look at another even longer term investment. The Boston Medical Center, and I'd paraphrase this as when a hospital decided housing was a critical priority. We met Boston Medical Center last episode through its food program, state of the art, first in the country. Their housing work tells the same story, but at a different angle, and deserves to be heard in its own terms. Because in 2017, BMC committed its entire $6 million determination of need contribution to housing. The first time any Massachusetts hospital had earmarked all of its community health funding to a single social determinant because it was that important. And the money didn't just fund a one-off program. It purchased and renovated affordable housing units, supported eviction prevention efforts, and built a housing stabilization program specifically for patients with complex medical conditions. Same rationale of the last episode, looking at their food program. And the Living Well at Home initiative and related programs have helped patients avoid eviction, exit homelessness, and stay housing long enough to actually manage diabetes, hypertension, and the other usual chronic conditions. That unstable housing makes nearly impossible to control. So the effect was predictable if you actually believe that housing is a health determinant, which BMC clearly does and has for decades. Participants showed up for appointments more consistently, filled prescriptions more reliably, and avoided many of the preventable crises that have previously driven up cost. ER visits and hospitalizations dropped for high-risk patients, and the hospital had every excuse to stay in its lane, instead behaved like an institution that understood where health actually comes from the community. Let's also look at another very unusual Blue Cross program, and that's Blue Cross Blue Shield of Minnesota, where I would see this as integration as prevention. Now, Blue Cross Blue Shield's Center of Prevention takes an integrated approach to these same upstream problems. Their mission is to transform communities by increasing access to healthy, affordable, culturally relevant food and eliminating the use of tobacco, commercial tobacco. Their population health strategy, it addresses the clinical issues alongside poverty and environmental factors, understanding that you can't separate the two. Same point again, underlies the majority of the successful case studies around the country, time and time again in the Health Equity Case Studies Handbook. So Blue Cross Blue Shield Minnesota is doing what health plans are uniquely positioned to do, using their scale and data infrastructure to identify where the upstream needs are concentrated, and then developing community partnerships at scale to address them. Tobacco cessation, food access, environmental health, not as separate programs with separate silos, but as an integrated strategy for transforming the communities where their members live. Again, an integrated strategy is a fundamental building block to scale institutional investment. It may start with housing, housing may be at the center, but it is part of a broader institutional investment and at scale. So I want to close with a few observations. We looked at 2 hospitals and a health plan, and the same underlying decision repeated 3 times. Stop treating the buildings people live in as someone else's problem. Now, can't we say that right across the board? But certainly in terms of housing, that stands out. Nationwide Children's spent $77 million and decided the whole neighborhood was the patient. Boston Medical Center handed over its entire community benefit fund to housing in a single year. Blue Cross Blue Shield Minnesota built prevention and housing adjacent investment into its core population health strategy. These are institutions choosing to act and at scale. In the next episode, we're going to look what happens when the institutions, the hospitals, the health plans, get out of the way and let the community make the call instead. So thank you for joining More Health, Less Healthcare. I'm Peter Boland.